Okay.
What are some actions you're taking to reach your goals to improve? So what actions are you taking to improve your goals? No. How do you think things are going?
I think they're going better.
Okay.
I think I'm starting to take a little bit more initiative and feel a little bit more comfortable.
Yep, I agree.
Especially after discussing things. I was like, I feel a little bit more at ease. One of my things before I started this clinical rotation was I tend to be very timid at first, but I have a big personality. So I hide it for a little bit till I feel like I trust people, and then I kind of like take my strides. And I think I'm hitting that, starting to like take my strides.
Yep.
So I'm trying to not have that buffer period or scale it back. So
Yeah, I think you've definitely made a lot of progress. Your confidence is definitely growing. You see it when you're going to the rooms. Like, I would say a week and a half, 2 weeks ago, I could be like, all right, let's have you work with this knee. Let's look at this knee, and you were kind of like, oh, like now it's like, okay.
yeah.
So your confidence is definitely getting better. It's continuing to develop in terms of your abilities to go in a room, especially with the older patient population. You're getting a lot more comfortable with that. So that's good, really good.
Our room shuffling is getting good too.
Yep, I agree. It's a dance. I agree. It's always fun, especially when you get Dr. Mahaffey in there. So let's see. What other things can we do to improve on the remainder of your time? We got about 3 weeks left?
Yeah. But then you're gone.
A week and a half.
Yeah.
I know. That sucks. You'll just have to tell Alan to extend your stay here.
Yeah.
Yeah.
I mean, we have a 3-week buffer before I start at Eureka, so.
Yeah, maybe. I mean, you're always welcome.
Oh,
so,
thanks.
I mean, just because of your rotations, you're always welcome to come in and learn, and so I'll let you know that. But, I think I wouldn't say there's anything necessarily we have to improve upon. I think it's just continuing to learn, and at least from my perspective, what are your thoughts?
I would say about the same thing, because it's just kind of getting that process down, and I feel like I have a semi-good process. It's just putting that implementation into practice, which, like we were saying before, this setting sometimes allows it and sometimes doesn't, just depending on the patient and the circumstances. So.
Yeah, we haven't had as many different things as sometimes we get a really good mix, and you get to see a lot of different things. We've had a little bit, so I'm trying to think.
The elbow injection was cool.
Yeah, I mean, I think you've been exposed to pretty much every joint. We've seen foot and ankle,
Seen lots of
elbow,
fingers.
knees, fingers, hand, wrist, shoulder. I think we've had one concussion, kinda, sorta. Yeah, and we're seeing somebody this afternoon that's not an injury at all. It's more of a consultation on diet and performance.
That'll be interesting to see and listen in on.
They reached out. The primary care reached out and kind of tagged sports medicine. It's a elite hockey player for a youth hockey player that's, I guess, concerned about his growth and just looking at ways to.
Is he short?
Yeah, apparently. I mean, I don't know. I didn't look. I haven't looked at his
Interesting.
vitals yet to see what is happening. But so,
Okay, interesting
so I mean,
to see.
so you've been exposed to pretty much everything we do for the most part, and the only other part of what I do is a lot of the cardinal stuff. It's just almost impossible to expose you to that.
Yeah.
It's hit or miss, right?
Or
it happens after hours. So, but I think so far you've done a really good job. I'd like to think that you're going to be really good with your knee evals and your shoulder evals, and unfortunately with the other stuff we just aren't seeing enough of that right now. And you're always, I mean, I know we talked about early on, but you're always, if we have downtime and there's something specific you want to work on, you let me know.
I feel like I'm getting better with interpreting the tests, not from positive or negative, but actually seeing what are the findings that I found on the test to make sense of it all.
I agree. I think it's almost having a broader differential of, I really think this. I think the one knee lady that we saw, the last patient this morning, you know, I came out and I'm thinking, hey, I think she's got a little medial meniscus thing. And I did think she had some pes anserine as well, but I was a little concerned, and you know, doc felt it was more truly just the pes anserine and more irritation where those tendons are coming down on that medial knee. So it'll be interesting, you know, to see like how she responds, and hopefully she does really well.
Yeah.
So, and then I'm always, like we talked about on our eval, I'm always going, okay, you know, maybe she would have been a good patient to do a Thessaly on, right? Because she's younger. So I look back in my own mind going, oh, we should have done that just to see, you know, if we got any different clinical information. So
I think that's something I've noticed lately with just like another perk of this clinical rotation is it kind of got me out of my head of what test do I need to perform? Why do I need to perform it? What is it that I need to see? What is it, like the positive findings? And instead it's kind of like just take what you have and then, you know, sift it through your knowledge. Like it doesn't have to be as book driven and concrete driven as like we're taught in class. You can just soak it all in.
Yeah, I think, you're right. I mean, you're using all that knowledge that you're taught, and you're just basically kind of molding it into your process of formulating a diagnosis. And all right, here's what I'm thinking based on the whole picture, you know. And as we say, I mean, I like to think that we could do the same type of diagnostics and do the same treatment plans if we were to get just a history. Because that's 90% of the evaluation, I think. And what's really nice is I've noticed is you're getting really good at knowing a lot of those questions. Particularly, I think we all have our go-to questions, you know, kind of what we're looking for. And you today, I was nice because you were asking the questions, and you know, like when we were conversing with the patient, and so I was able to actually, you know, get the information in the chart, and because you're developing that understanding and that flow that we talk about, and so that'll be nice when you go back and you're working with a athlete at Eureka. You're going to find yourself saying, "So, does it bother you when you sleep at night? You notice any radicular?" Yeah, you're like, "Oh wait, this is my routine." So that's good. I'm definitely seeing the growth with that on your part. So very nice. I can't read that far.
What can you improve on with the rest of the time?
Just keep learning. Yeah, I don't know that there's any. I mean, I think we're always improving. Even myself, you know, constantly. I've been doing athletic training for about 27 years now, I think, or maybe it's 26. The only reason I know that is I got my 25-year pin.
Nice.
I think it was last year or 2 years ago, yeah. And I feel like I'm still constantly learning, whether it be from Dr. Mahaffey or Dr. Lippy or Dr. Nawas. Like, even Andrew, like our PA, he's awesome. Like, he's a really good teacher, and so I'm always trying to learn. Just always trying to. So that would be my recommendation in terms of improving. Just constantly learn, soak it all up, listen. You know, you do a very good job of not sitting behind your computer. And what I mean by that is it would be very easy that, oh, we're not seeing a patient in the room. I'm going to sit and I'm going to work on whatever work. You do a really good job of being around the clinic and listening to conversations, and that's how you learn. And so that's really good. You can keep doing that.
Always have an ear on everybody else.
Yeah, well, I mean, Andrew might have a patient that's totally cool with a really unique case, and you overhear that, and hey, go hop over there, and you know, or if we're ultrasounding a wrist ganglia, right? Like, yeah, hop in there. Like, you're gonna learn more from watching that than me typing a note, right? So you've done a good job of that, and it's a good opportunity. So take advantage of those. Clinical case, questions about or any complications? What do you think?
I don't know. We're pretty good about after we see somebody that we kind of like hash it out. I'm really curious about that girl that was like disc,
yeah,
disc.
Yeah. You know what, and I haven't looked. I'd like to look at her MRI report. We can pull it up just to see maybe what was on that, because I would have bet the house that it was a disc.
Yeah.
And you know, and I do know that I think he's going to do a heavy steroid taper with her and get her into therapy. So it'd be interesting to see how she responds. if she doesn't, I don't know. Yeah, I don't know what you do. Maybe you image your brain. It sounds crazy to say image your brain, but you look and make sure there's not some sort of a brainy tumor or something totally out in left field. But so presentation would have been disc, all the way.
Yeah, that was an interesting case. I'm curious, to see what they do for rehab for that.
Yeah.
Because she could not move. So what are you going to do in rehab if she cannot move?
Yeah.
Soft tissue work, maybe?
Yeah, I think that, and obviously they'll probably work on her breathing patterns just to try to get everything to reset, and then from there probably work on some
abdominal bracing,
core bracing, and then probably start doing some thoracic and low back stabilization stuff. I don't know. I mean, they're so adapted when they do their movement screens and all, finding even the smallest little thing that can make a big difference, right?
Yeah.
And if I remember correctly on her exam, she didn't have a leg length discrepancy. So, sometimes you think about that, if they have a leg length, but like a true leg length, but typically they're going to be more chronic back pain.
Yeah.
And she didn't have any fractures on her MRI or even on her x-ray. So it was unique. That was a unique case that it's one of those that it presented and the findings were like, whoa, that's really surprising. We'll get a couple of those. We had a baseball player that came in. I mean, that's our bread and butter, right? Baseball. And we would have bet the farm that it was an ulnar collateral on his elbow, and his MRI arthrogram came back like stone cold normal. And we're like, what? And we get the kid over the therapy and all that, and really it was just, he had some inflammation, but after getting everything to reset, young, loosey-goosey athletes, we teach them the breathing, teach them the stability, and all of a sudden everything feels better. So, I don't know. I always say, a mentor I work with always said, it's seen you, but you haven't seen it. And so, even when we think we got it figured out, the body is amazing, and it's going to say, nope, trick you, haha.
It's also been interesting this week, because you've had 2 peer-to-peers this week that you've done. So I think that's been cool to see that side of it.
Yeah. I mean, I don't enjoy doing peer-to-peers because I think it's a waste of time. And it's unfortunate the healthcare system and the insurance industry is dictating healthcare. Part of me tries to understand the cost component on the insurance side, but it's hard to have a physician that's never seen a patient trying to dictate, what the appropriate, let the physician who's managing that patient's care dictate that. And but I feel fortunate that I have the whereabouts to be able to help Dr. Mahaffey, so he's not tying up clinic time and other time focusing on mundane, BS like calls. At the same time, there's still challenges with that. I mean, there will be a few times where I'll attempt to do peer-to-peers and they won't talk to me because I'm an athletic trainer. And it's
QC for athletic trainers.
I've had those discussions with some of the committees that I've been on in the past, and it's something that we're, as a profession, continuing to work on. I think some of your insurance industry, your big players are recognizing athletic trainers, and so I think it's just a matter of time. Just got to keep plugging on. What we can do.
Goals for next week? Week 6? Is it next week that he goes out, or is next week the last week?
No, it's next week. He'll be out. So probably what we'll do next week, with him being out a little bit, is we can dive into, play around with a little bit of the administrative stuff, just some of the behind the scenes stuff that maybe like I do or that Matt does that maybe aren't necessarily clinical in the sense of seeing a patient, but help with that process, whether it be the prep work or follow-up work. We can just kind of look at some of that. Maybe we can play around with Epic a little bit on how that, like documentation, like we talked about that, like we'll, give you some pearls of wisdom just from experience, and But then also we can maybe, spend a little time over on the therapy side, or, I mean, there may be who knows? I mean, every day is a different day, but there'll be some of the days that we'll have some of the draft players coming in, so maybe an opportunity just to see, how that process takes place, because I'll be helping with that and give you a chance to see that. And there's always a chance I could get called to Dr. Greiner's clinic if Tammy's sick, and so we never know, right? We're athletic trainers, so we just kind of are ready to go. So, but I think we can dive into maybe some of that stuff that when we have patient care, we haven't been able to necessarily, either review or have, converse about. So, and then we'll talk about getting things set up with therapy, just whether it be with Colin or Megan. I would say kind of we have the opportunity, spend a little time with each of them, because they're all a little different, right, in their ways. So I think they all teach a little differently too. So that's my thought.
Yeah, sounds good.
Cool. Good job. Good week.
Yeah.
Short week,
yeah.
but it's good. Short but busy.
Sure.
That's for sure.
Right. And this.